So as Andy said, my name's Gemma. I've been a physiotherapist for just under 2 years now and practicing pelvic floor physiotherapy for that whole time as well. I did my schooling at U of T and then my kin degree at Western. And I've been, like I said, doing pelvic floor physiotherapy almost since I started, so just about 1.5 years now. Today, our presentation is going to be about pelvic floor physio, but then also related to core system and weightlifting. So we're going to try and make it as applicable to you guys as possible. How many of you have heard of pelvic floor physiotherapy or have referred to pelvic floor physiotherapy before? Cool. And just out of curiosity, right off the bat, anything specific you guys look for or would be oh yes, that would warrant a referral? Yeah, cool. Yeah, cool. And that's what we're going to be talking about today. So we'll get a little bit more into that and then also chat about some other things. So this is our agenda for today. So we'll talk a little bit just about anatomy and function of the pelvic floor. Role of the pelvic floor in core and weightlifting. We'll talk about some bracing strategies and how that relates to our core system. Weightlifting in pregnancy and postpartum, as well as perimenopause and postmenopause. So just some very small tidbits around that. And then some specific pelvic floor muscle train. We will do some practically. So meet your pelvic floor. So we have some fun images here. You do not need to know obviously all of this, but we'll just chat briefly about where the pelvic floor muscles sit and their function. So the pelvic floor muscles start at our pubic bone and run kind of like a hammock and attach at our coccyx. So you can see here, pubic bone coming all the way around to this bone here. In that image, you can also see that they run kind of right underneath rectum. Oh, this is being a little glitchy. Oh, okay.
I'll do it this way. And just step it down.
Yeah.
I went a bit slow.
Yeah. Oh, good. I'll put it down. So you can see there it sits underneath rectum, uterus in women, and then bladder, and they support these organs. So that's kind of one of their roles. They're also the sphincters for bowel and bladder function. So anytime you're holding in pee or poo, that is your pelvic floor muscles contracting. Not really pictured here, but it's also important to note that a lot of these muscles share connection points with a lot of our external pelvis and hip musculature. So some really important ones to note are the abdominal attachments, inner thighs, our deep hip rotators, and our hamstrings. So they can all kind of play into each other because of their very common fascial connection points. And then this is our core system. So our pelvic floor is part of a whole 4-part system. And basically what the system does is works to accommodate changes in intra-abdominal pressure. So it really needs to be diverse in the sense that anytime we're changing activities or movement patterns, that intra-abdominal pressure is also adjusting and changing. So as you can see in this kind of moving picture here, our diaphragm, our pelvic floor, and our abdominal muscles all kind of move simultaneously to accommodate these changes. So for example, as you take a deep breath in and your diaphragm moves down, your pelvic floor should kind of involuntarily also relax at the same time, and that the abdominal wall should expand. And I'm sure you've all maybe at some point taught diaphragmatic breathing or lateral costal breathing. So that is kind of a very good example of what this would look like. And then kind of similarly, as the abdominal wall comes in, that diaphragm lifts up, that pelvic floor should also lift up. So another example is if you're teaching transverse abdominis contractions, you might have also cued that pelvic floor contraction as well, because generally they should happen at the same time. So let's just do a quick exercise. We're going to try and find our pelvic floor muscles. So I'm going to get everyone to sit up nice and tall in their chairs. Cool. And you can just grab a hold of your hip bones, and I want you to anterior pelvic tilt just slightly so you can kind of feel the base of your seat against your chair. And you can flip the slide there, Andy, if that's okay. So we are going to do some pelvic floor muscle contractions. So you can kind of read through these 3 cues, try a couple of them, kind of figure out which ones resonate best with you because it's going to be different for every single person. The most common one is stopping your pee midstream or contracting like you're trying to hold in pee or poo, because you can do contraction from urethra or from the rectum. Some other ones like lifting a blueberry up into your urethra or pretending your pelvic floor is like an elevator. So you're closing the doors and lifting all the way up to the top floor. Anyone have any questions about that or don't know what they're supposed to be feeling? All good? Okay, cool. You can switch slides there, please. Thank you. So we will do some relaxations as well, but before we get into that, I thought it was really important to mention that a Kegel isn't just like a single contraction, kind of just like any other skeletal muscle fibers in the body. There's type 1 and type 2, so they also can generate like power, strength, endurance, and then they can also relax. So if you ever are, for some reason, doing like very specific core system training and training for like a specific activity, whether that is like strength, endurance, power, you can also train the pelvic floor to do those things. So you can do a hold, you can do like a quick muscle contractions, you can do strongest hold you've ever done and hold it. So there's lots of variety to that type of training as well. And it's also important to note that I wrote the pelvic floor of athletes, but to me, like an athlete is anyone who's exercising really. So anyone you're treating, pelvic floor needs to be a lot stronger than in like the regular population, because ground reaction forces are much higher in running and in weightlifting than just like walking around doing day-to-day things. So 3 to 4 times body weight when running, and then 9 to 12 times when jumping. So that is a lot of force going through that muscle. So same thing, sit up nice and tall, find that kind of seat against the chair, and we're going to try and relax the pelvic floor. So this one is like pretty much exact opposite to what you just did. So relax the pelvic floor as if you were trying to pee or use the washroom. And you can also picture the space between your sit bones separating. And another one that's kind of funny but works really well for a lot of my female clients is like picture like a flower blossoming out of your vagina or out of your rectum. Does anyone have any questions about that, or again, not know what you're supposed to be feeling there? Yeah.
For the relaxing, are you supposed to feel something, or is it just like,
So
is it already relaxed? Like,
that's a very good question. So you might not, and you might. So a lot of people sometimes hold more resting tone in their pelvic floor than normal. So if they voluntarily relax, they might feel like a drop in their pelvic floor. But if you already sit at like a regular resting tone, you might not notice anything. There's also such thing as like too much relaxation, and that is called bearing down. So that would feel like extra pressure coming downward. So if you are sitting in a chair, you might feel everything like lower down into the seat, if that makes sense.
and that's too much.
I would consider it bearing down, yeah, which we will talk about. All right, so some brief function of the pelvic floor. We talked about obviously like bladder and bowel control and function. It's also a big player in sexual function, so having comfortable intercourse and orgasms. Your pelvic floor needs to be able to like fully contract and fully relax for that to be comfortable. It supports and holds up our pelvic organs as mentioned. It's also really important in circulation. So it acts as a pump for blood and lymph and moves fluid kind of in and out of the abdomen and pelvis. Also boosts circulation, can decrease swelling and bloating. It's a stability muscle, so your pelvic floor and abdominals work together to stabilize and support movement of low back, pelvis, and hips. And then breathing, again, as mentioned, muscles react and control changes in intra-abdominal pressure by working with diaphragm, abdominals, and multifidus. So let's talk about a couple analogies that I find, again, really helpful when chatting with clients about these types of things. So the first one is our trampoline analogy, and this is going to describe the like shock absorption and recoil function of the pelvic floor. So I like to describe the pelvic floor as a trampoline, right? It needs to be able to recoil when there's pressure put on it. So for example, if you put a ton of bricks on a trampoline, it probably wouldn't have that same recoil, and I like to compare that ton of bricks to like a lot of pressure down on the pelvic floor. So that could be anything from like bearing down to holding your breath to even just like the type of lift you're doing or the amount of load you're adding to a lift. So bottom line needs to have that nice recoil and that bounce to be healthy per se. That second analogy is our soda can analogy, and this describes more that like strong core system. So if you have a closed can of pop, all 4 walls are going to be pretty strong, right? So all around that can, like if you tried to break it with that closed can, it's not going to break. The second you open that can of pop, which could be considered to or compared to dysfunction in like one of those core system areas, so like our diaphragm, abdominals, pelvic floor, multifidus, it's going to be a lot easier to break. And that breaking can kind of be compared to dysfunction of the pelvic floor. which we will talk about in the next slide and what that looks like. So how do you know when things go wrong, or what might people report if they are having pelvic floor dysfunction? So it occurs when pelvic floor muscles lose strength, flexibility, coordination, and or responsiveness. And it might feel like heaviness, bulging, or fatigue in the perineum or the vagina. Leaking urine or stool, even just like the tiniest amount, isn't normal. And that could be when exercising, sneezing, laughing, coughing, but it could also be like even like urge incontinence. So when they have to pee, when they like feel the urge to pee, and then a little bit will leak out. Pain during intercourse, inserting a tampon, or during a gynecological exam, or pain in any part of the pelvis as well as low back or hips. So someone who has like chronic hip, low back issues. It's very, very common to have that pelvic floor dysfunction related as well. So because this is the most common one, we're just going to touch on it briefly. So the definition of urinary incontinence: complaint of any involuntary leakage of urine. There's stress incontinence, so that is that change in intra-abdominal pressure causing that leakage. Urge, which is when you have to pee and you have a little bit of that leakage, or mixed. Stress and mixed are definitely the most common in any sort of person who exercises, so that's probably the ones you'll come across the most. It is reported in a study 48.8% of people who weightlift reported urge incontinence. And in the general population, we have a pretty big range, 10 to 55% in 15 to 64-year-old women reported stress incontinence. General risk factors: age, number of pregnancy, body mass index, years, strength, training, and then our next slide we'll talk about activities related risk factors. So these ones might be a little bit more applicable to you because these are things that you can manipulate when you're seeing a client or doing exercises with them. So we have load, so that just means like how heavy weight they're using or not. Type of activity, so whether that's like weights, cardiovascular, plyometrics, things like that. Type of lift will play a big influence, so deadlifts might cause more symptoms than squats, which might cause more symptoms than like a chest press, for example. Fatigue, so again, that varies day to day, person to person, so that can have a big role on symptoms. Body position, so are they in more of like an anterior pelvic tilt? Do they have like a rib shift? Are they rotated at the pelvis? Those are all things that we're not necessarily trying to fix, but can definitely play a role in their symptoms. And then I don't know if any of you have experience or like ever use lifting belts with any of your clients, but that can definitely play a role based on like bracing strategies or like tightness of the belt or what strategies they're using to accommodate that. So now we're going to talk about actual bracing strategies and what those look like and what might be most optimal. So abdominal bracing is a voluntary contraction of the abdominal muscles to increase stability of the spine and may increase intra-abdominal pressure. So this is probably the one you might use most. It can also be accompanied with the Valsalva maneuver. Forced exhalation against a closed glottis used for heavier loads, and then bearing down, which is kind of what we were talking about with your question. So that's a voluntary relaxation of the pelvic floor muscles so that any buildup of intra-abdominal pressure is being sent downwards rather than like up or out. And then optimizing how you brace can influence ultimately like your performance. Just out of curiosity, like have any of you used these bracing strategies or cued them or have had any success with one versus others? Yeah.
Yeah, intra-abdominal pressure.
Nice.
Yeah, it's hard for me to like, it's always found it really hard to teach kind of like the Valsalva maneuver.
Totally.
It's almost easy to teach IAP.
Yeah, absolutely. Cool. Cool. So we're just going to talk about the toothpaste analogy and how that relates to bracing strategies, and then we will try these bracing strategies out. So image A kind of depicts more of that generating pressure from the bottom first before we load from the top. So basically what that means is we want to generate that strong kind of bracing strategy before we add load or before we do our exercise. picture B would depict more of loading from the top first, so loading from that like closed glottis position or from the upper body in terms of just upper body exercise, which causes pressure to migrate downwards. And now in general, pelvic floor has to kind of cope from a place where it isn't braced at all, and now we're adding load on top of it. So I like to kind of compare it to, like, in general, if you are about to do something forceful, it's a lot easier to brace first and then do it rather than to do it and then try to create that brace on top of the load that's already there. And then image C would depict that core or abdominal bracing where you brace from the center first, and then pressure is either going to move up or move down, which isn't necessarily a bad thing, but depending how they do it can lead to like acid reflux or stuff like upper, or incontinence or prolapse things from the base. I will say right off the bat, like, none of these bracing strategies are good or bad, or there's not like a hierarchy of which one you should be using. It's like highly based on symptoms and personal preference. So that's where a lot of like trial and error, like test, retest things would come in. So we are going to talk about some load transfer tests, and I'm going to use Stephen to demonstrate some of them, and then you guys are going to pair up, do these load transfer tests, and try some of the different bracing strategies with these tests.
Yep.
Cool. So a lot of these are quite simple, and basically they're just used to assess like which strategy is going to be best for someone. So you're basically just assessing like increase or decrease in performance or strength or symptoms. So the first test is the arm test, and it's basically just like a shoulder flexion test. So Stephen's going to stand with his arm out straight. I'm not going to cue him at all the first time, and I'm just going to apply pressure just proximal to the elbow, support at the shoulder, and just apply downward pressure. Good. And then it's hard to tell like how someone's bracing initially, so I can just ask, like, did you have any bracing patterns during that?
Tried to brace from the bottom up, and then I was breathing the whole time.
Okay, cool. And then again, if they're strong or like if there's no symptoms, you can just move on. But if, for example, like I could push his arm down very easily, or they reported symptoms, whether that's that pelvic floor symptom or like hip or low back pain or something like that, then I would cue them for a different bracing strategy and try it again. Okay. Next one is the leg test, which I now realize you need to get down on the floor if you're okay with that. Cool. So this is very similar to like a straight leg raise test if you've done it. So he's going to lift up to about 45 degrees. I'm going to come again proximal to the knee joint and just apply downward pressure here. And then I'm just looking at symptom reproduction, ability to hold, bracing strategy if I can see it. Sometimes you can see if people are holding their breath, stuff like that. Next one is the push test, which is a little bit funner, so you can stand up. So what I'm going to do is I'm going to come into like kind of an athletic stance here and put my hand on Stephen's shoulder, and he's also going to come and match my position here. If arms can reach, you can like put your hands on my ribs, but if not, you can also just keep them where they are. And basically what I'm going to do is just apply like a backwards push position and kind of look again what they're doing. And then the last one is a bump test. So Stephen's going to stand in like, again, that kind of wide athletic stance. And I'm just going to come and like give him some shoves from like different angles. And that can kind of, again, depict like what kind of strategies they're using. So I'm going to leave this slide up. Everyone can get into pairs, try those out. And I just want to know, or I'm curious to know, like what kind of bracing strategy was the most common, or if one worked better for different people. So I'm just going to quickly chat about a couple things that came up during that. So Lav asked a great question about if they are experiencing any sort of urinary incontinence, if that's like kind of like a contraindication, or if you should stop what you're doing. And my answer to that was no, not necessarily. You definitely don't want to be giving them exercises that like reinforce that incontinence. So really like seeking feedback from them about like what's working for them and what isn't, and what their comfort levels are as well. But they should absolutely continue to train. And you should also make sure that they are seeking some sort of treatment, because by no means is leaking normal or should be happening, and people should know that. So if you're there to support them and be like, yes, like this is what you should be doing, then they'll feel a lot more like confident in those decisions, if that makes sense. Second thing was Stephen and I kind of found that that like definitely like recognizing bracing strategies while you're doing this is a challenge. But what he went around and was saying was, if you're doing these tests and you're like, okay, can you talk to me during this? How does that change? Or like, if you're just breathing through your nose, how does this change? If you hold your breath while you're doing this, how does this change? So those are nice ways too, rather than just being like, am I squeezing my abs or am I at some point, because things are probably not going to feel good at certain points in the pregnancy, and it might feel really good at other parts or postpartum. They do generally need some sort of exercise clearance from doctor postpartum, so you want to make sure they have that. But within that time, like, they are still doing a lot of things at home that would warrant some sort of like muscle contractions and physical energy. So doing some sort of like movement activity patterns from that like 0 to 6 week postpartum mark is sometimes warranted as well. Diastasis rectus abdominis management, I linked something in the PowerPoint for that. I'm not going to talk about it a ton because it's a whole other thing on its own, but you can definitely still train with it, is kind of the bottom line. And again, just recognizing precautions and contraindications, and those are things, again, that their GP will probably tell them. And I also put a link in the PowerPoint that you can refer back to if you ever need any of those things. And then perimenopause and postmenopause. So this refers to that like during menopause period, when we're like, oh, I'm going through menopause, and then that postmenopause period, so when they're actually done. Again, I would say exercise is like even more encouraged because we know bone mineral density is starting to decrease, so exercise will promote that. Important for heart health, musculoskeletal health. It does support genitourinary syndrome of menopause, which that just refers to all the symptoms that women obviously specifically go through during menopause, whether that's like genital changes, sexual function changes, bladder, bowel changes, things like that. And usually they'll be seeing one of these 4 practitioners or a pelvic floor physio for these things. So again, just making sure those proper referral sources are sent out. And then again, nutritional needs, which is the job of like dietitian, naturopathic doctors. So that's kind of like the team that you would be looking at in those populations. Cool, so now we're going to take what we learned pelvic floor contraction wise, pelvic floor relaxation wise, and bracing strategy wise, and make it a little bit more functional. So we're gonna skip, I think, the first 2. Yeah, skip that one.
This exercise will take us through.
And then we're gonna go to the, I think, skip to 1 more. So these ones we already did, and they're just videos that you can refer back to if you need. And skip this one more. Cool, so we don't need to watch this right now, we can just chat about it, but again, you guys can watch this if you need something to refer back to later on. So we are going to, you can either stay in your seat or lie down in a comfortable position if you want, and I'm just gonna go like take you through what's considered like a functional Kegel or functional core strengthening exercise. Cool. So what we're gonna do, we're gonna place our hands either on the hip bones or on the rib cage to feel our breathing pattern. So what we're gonna do is talk about or kind of cue through that like core breathing, so that diaphragm movement mixed with that pelvic floor movement. So for a few breaths in a row, we're gonna inhale, and as you inhale, you're gonna picture your pelvic floor relaxing. So we're gonna combine the two. That relaxation of the pelvic floor should happen on the inhale, and then as you exhale, you're just gonna bring everything back to neutral. So it's a little bit confusing. We're gonna cue it a few times. So you're gonna inhale, relax the pelvic floor as if you're trying to pee. And then you're gonna exhale, feel that belly and those ribs draw back in. You're gonna inhale, relax as if you're trying to pee, or picture those sits bones separating. And then you're gonna exhale, just draw everything back into center. Couple more times. Inhale, relax the pelvic floor, feel that seat lowering down into your chair, and then exhale, bring everything back together. Okay, if that was good, we're gonna do that first part, but on the exhale, now we're gonna add a pelvic floor contraction. So like we talked about, when we engage that core, that pelvic floor should automatically kind of contract, but we're just gonna cue it voluntarily this time. So as we inhale and relax the pelvic floor, we're gonna exhale, feel that belly draw in and that pelvic floor lift up. So it's like you're inhaling, filling up that like whole balloon, everything's expanding in every which direction. And then as you exhale, everything's drawing into center. Good, we'll do 2 more. Inhale, feel that belly expand and that pelvic floor move down. And then as you exhale, everything's drawing back into center, so belly comes in, pelvic floor draws up. We'll do 1 more. Inhale, belly expands out, pelvic floor moves down. And exhale, belly moves in, pelvic floor draws up to center. So it's a lot of coordination. It's a lot, and like usually it takes a lot of practice to be able to like coordinate these things, because it's also like very opposite. I find anyway when I teach people, they're like, oh, that's like completely different than what I thought it was supposed to be. But basically that's promoting that healthy movement of like our entire core system to maintain that intra-abdominal pressure. Does anyone have any questions about that? All good? Cool. And then the last one we're gonna do is we're going to apply that to a dead bug. So I actually do want you guys to get on the floor if you're okay with that. If not, that's completely okay. Cool. I'm assuming everyone knows what a dead bug is. Does anyone not?
We're all in the right position.
Yeah, totally. Okay, so we're just gonna do the legs. You can ignore the arms for right now. And I'm gonna cue it kind of how I would generally cue it, and then I'll tell you kind of how else you can do it as well. So you're gonna lift those legs up to that tabletop position. And I want you to think about those breathing patterns we just did, but now we're applying it to a more functional exercise. So as you lower one leg, you're gonna inhale, relax the pelvic floor. And then as you lift, you're gonna exhale, create that strong contraction in that pelvic floor and abdomen. Good, you're gonna inhale, relax the pelvic floor. And exhale, draw everything back together. Good, if you want, you can try the opposite. So take a deep breath in before you go. Exhale, contract and lengthen. And then inhale as you draw everything back in. This is definitely dependent on personal preference. Some people find the harder part of the movement is that dropping of the leg. Other people will say it's the bringing in of the leg. So I would say there's no right way to do it. But as long as we're pairing our breathing with one part of the movement, this again is accommodating that change in intra-abdominal pressure and making sure all 4 parts of that core system are working nice and optimally. Good, and once you've tried both of those versions, you can just stand up.
There's like common mistakes you'll see and stuff like how to fix those common.
Totally, totally.
It's hard to do that right.
Yeah. So I would say the purpose of this, and the most common thing I tend to see, at least when teaching any sort of core exercises, is like people love holding their breath, which again, maybe in certain contexts is okay. But if we are, again, training this exercise for the purpose of training their core system, you do want to see breathing, whether that's on the lower or the up, it doesn't really matter. Common things I tend to see as well is like a big, like nice anterior pelvic tilt that happens as people lower their leg down, which again, for the purpose of the exercise, we're promoting that like stability through the core. So we just want to make sure that they don't necessarily need to be like back flat against the ground. A little like pea-sized space is okay because that's that natural curve, but we want to make sure that like space isn't changing with each movement. Does that kind of make sense? Cool. Anything else you want to add that maybe you sometimes see in this exercise?
I think another common one is when the leg drops down, the opposite pelvis will start to lift up. So we know that's that kind of contralateral sling system. So it's another thing you want to think about. I find people can be really good at it without breathing, but as soon as you add breathing, everything kind of changes. So it's just kind of nice that you can try different things in different cues and just see what people can do. And you can do so much with that exercise related to pelvic floor stuff, but also core stuff too. So, yeah.
Cool. Couple last things.
This video will take
So we're just going to run really quickly, like just so you know what a pelvic floor physio session looks like and kind of like what you're getting your clients into if you do happen to refer out. So definitely like all practitioners are different and will practice differently, have different levels of training. But generally what happens is, like any other session, there will be a subjective history. It will be mainly focused around their like main complaint. But in general, you want to touch on like bladder, bowel, sexual function, maybe any obstetric history, gynecological history, and mental health. If you do send males, we'll touch on like prostate health as well, again, depending on their complaint. Generally don't tend to probe about things that they're not specifically coming to you about, but sometimes gathering information about things that, again, they're not necessarily complaining about just gives a really nice indication on like what's happening as a whole. And then the other important thing about the subjective history is sometimes they'll report things to you or like behavioral patterns that can be adjusted and accommodated for that can overall affect their pelvic health. It's not necessarily like, are you weak or are you strong? It could be like, what are your like bathroom habits? How is your stress levels? Like, what's your lifestyle like? So there's a lot of things there that can play a big role into pelvic health as well, not necessarily like what's happening objectively, if that makes sense. External assessment, so this is kind of just like a general orthopedic type assessment, focused usually around like low back, hips, abdominals, and pelvic floor. So some specific things that I always look at is like just pelvis and like SI joint mobility. It will test some functional positions, so like squats, lunges, forward bending, things like that. And then I usually always assess breathing patterns, again, just getting them to lie on their back and saying breathe like you normally would, looking for like if they're indrawing on their inhale or like puffing the belly on their inhale, things like that. An internal pelvic floor assessment, sometimes warranted, sometimes not. Sometimes people want it, sometimes they don't. It's 1000% optional. It is like the standard, like the hallmark assessment for assessing pelvic floor musculature. So most people, like if they know that's what they need, they will consent to it. And it is a digital exam. I don't know, do you guys know anything about the internal pelvic floor exam? Yeah. So I'll just do like a really brief assessment of, or brief description of what it's like. So it is a digital exam, like I said. Generally, you're just feeling for like tone. You're getting like their feedback on how things feel, because it's very similar to like, I don't know, if you're like poking around someone's glutes or low back and they're like, oh yeah, like that's quite tender. It's very similar internally. It just feels usually like 10 times more tender than it would externally. So you're looking for that. And then that's where you would do your strength testing as well. So very similar to like regular strength testing, it's graded on a scale of 0 to 5, and it's based on like strength, so like they're that maximal contraction, and then endurance and speed contractions as well. And then once that assessment's gathered, you get into treatment. So we'll go to the next slide and then just give some examples of like what treatment can look like. So we have that specific pelvic floor muscle training, whether that's like that relaxation that's required, or that contraction that's required, or that different type of contraction that's required. Bladder and bowel training, lifestyle changes to optimize bladder and bowel health, movement strategies and modifications, breathing techniques, tender point pain release strategies. So you can do like self-internal release, or there's like a lot of tools to allow you to do that as well if that's necessary. Just general strengthening and mobility exercises, especially around like hips, pelvis, low back, core. And then manual therapy as well. So low back, hips, groin, abdominal work, and or like pelvic floor, again, internally specific. Does anyone have any like last minute questions or anything?
Yeah. When you're doing like your breathing exercises on the ground, do you ever, like sometimes like describing the sensation of your pelvic floor contracting, like exhaling is hard.
Mm-hmm.
Do you ever give them like a constraint, like say yoga block in between the legs to like get the adductors to not fire too hard, but just a little bit, just to get like the exhale position of the pelvis so they can kind of feel something?
Yeah, so that's a great question. So you're right, sometimes activating the adductors can also influence like that pelvic floor contraction, if that's what you're referring to.
Yeah, mutated sacrum.
Yeah, and another thing that like they might not always be comfy doing like with you in session, but you can always get them to put their hand like on their perineum. Does everyone know where your perineum is? Yeah. You can get them to put their hand on it and they should be able to feel like a lift of that with that contraction. So that's also a really nice way. That's, I find, a lot more direct than activating inner thighs, because sometimes you can actually like over-activate inner thighs and make that contraction strategy rather than the actual pelvic floor, if that makes sense. Yeah?
Also use a Swiss ball to give you that pressure from the bottom.
Exactly, yeah. So sitting down tends to help. You do just want to make sure they're a little bit like rolled forward so they're right on top of that, again, perineal area.
Something really recently that I found worked so well is if they just like straddle the like bench.
Yeah.
And then they can literally like sit so upright. It works so well.
Yeah, that's a really good one too. Yeah, any sort of like tactile feedback I find works wonders. So if you can get them in like a comfortable position, or if they're comfortable doing that, and then their hand at home if they need it. Yeah.
How long does it typically take, like a treatment plan course, like say someone with incontinence?
Totally. So it's different person to person. Like, I've treated a lot of urge incontinence, I would say a little bit more than stress, and urge tends to take way shorter. Like, I've had people like change a lot of behavioral stuff, like bathroom habits, and by the time they come back in like 2 or 3 weeks, they're like, it's like 80% better, which is awesome. Stress incontinence, because you have to consider a lot of those bracing strategies, can somewhere take like, again, like that like 8 to 12 week timeline I normally say, but it also depending on if they're compliant with like their home exercises and stuff like that. Like if they're not doing absolutely anything between sessions, then it's going to be a lot harder. But yeah, I've had people I've been seeing for like a year and a half, like every 3-ish months, and like it's a very, very slow build, but it's so variable, unfortunately. Yeah. That's okay.
For like an urge incontinence, are you seeing more pelvic floor that's like too concentric or like too eccentric, or is it kind of like 50-50 across the board?
Totally. So that's a great question. I would say it's a lot. I've seen very commonly where people are like in that more like activated or like concentric contracted position, because what happens if like someone doesn't have that ability to relax and they're already sitting in that contracted position, they like can't activate. They have nowhere to move, right? So it's not necessarily an issue of like, oh, they're not strong enough. It's like, oh, they actually just like have no range of motion. Does that make sense?
Yeah. It's already short.
Yeah, it's like trying to do bicep curls like this, like nothing's gonna happen, right? So if you're here, just, yeah.
Why do you think that incontinence is so much more common in females?
That's a great question. There's a lot of research about like, it's more so like stress related and lifestyle related, and it's very common like postpartum, because again, this is all research based, it's not my opinion, but the like ability of like the taking care of like other humans rather than taking care of yourself. Like it's very common for women to come in like 20 years after having kids and they're like, I never had time to come in, when like these things probably could have been way easier addressed when they came in directly postpartum, but they tend to like not take care of themselves maybe as well as they should, because they feel so much pressure to take care of babies and family and things like that. Yeah.
Another thing too is a lot of evidence that men just don't come forward when they have issues, so it's kind of skewed that way. That
Totally.
Obviously, females that are saying they have pelvic floor related problems, even though there's a lot of men that probably need this too, just as importantly. So
absolutely,
education's really helpful for that. Like, that's why you guys are the front line of.
Yeah. Every time I get a male client, I'm like, yes. Yeah. Cool. Well, thanks for listening.
Great.